So it's great to be here. I would have rather be with you in person, but these are the days we live in. So I am no longer the Vice Chair of Education. I think you've met Dr. Fernandez, who has that title now, and I am the Emeritrix. So I'm 70 this year, and I decided it was time to move into other things that I want to be doing in geriatrics. So she gets to do the hard work, and I get to have the fun. We're going to talk today on, let me just make sure I can get these to move. There we go. These are our objectives. And the first is to talk about the trajectory of outcomes for older adults. So you guys tend to see folks for a very limited amount of time. You see them after they're admitted usually, and when they're discharged. And there's a life hopefully after that. And the question is, what happens to them during that time? I want to talk about something called hospital-acquired disability and something called geriatric syndromes, and convince you that hospital-acquired disability is actually a geriatric syndrome, far more likely to occur in older adults. I want to talk about the interaction of bed rest with the physiology of aging. And finally, talk about how to prevent the hazards of hospitalizations, what you can do and what the system can do. So to begin with, why this talk? And I think it's pretty obvious, but this is the percentage of the population that's 65 or older at the moment, 17%. That's going to go to 20% pretty soon. And this 17% makes up 39% of all hospital admissions and 45% of all hospital days. So you're going to be seeing a lot of older adults in the hospital. So I don't have a Zoom poll because I wasn't clear that this was going to be Zoom. So if you want to just scream out your answers or raise your hands or put something in the chat, actually that might be the best thing to do. Put your answer in the chat, okay? The question is, what percentage of hospitalized patients who are my age or more are discharged with a new activity of daily living disability that they didn't have prior to becoming ill? So we're talking about the ability to walk, the ability to dress yourself, the ability to get to the toilet, the ability to take a shower, okay? How common are these problems? And so we have a lot of D's and a lot of C's. That's what I'm seeing here. Actually, this is my gestalt, is that the D's are outweighing the C's, but 30 to 50%, whichever it is, it's not good, right? So here's the answer. The outcomes, 30 to 40% lose one or more basic ADL at discharge compared with pre-admission. So we use the term pre-admission to being 2 weeks prior to admission, because when you start getting sick, you may lose some ADLs. So we want to know what baseline do we want to get our patients back to, and that's pre-admission. And as I'll show you even more in a few minutes, a lot remain impaired 3 months later and even a year later. Hospital-acquired disability is what we call this. If you take a look down here, you can see that the initial studies were in the 1990s. But when repeated in 2011 around the world, unfortunately, things didn't get a whole lot better. The one thing that got a little better in this country were the percent readmitted within 30 days. So it used to be 20%, now it's 16%. And so maybe we're doing something a little better. This is a confusing chart. So let me walk you through it. What we're looking at here are baseline, which is what we just talked about, that 2 weeks prior to admission, looking at 2,300 patients. Admission, when they were admitted, 57% were at their baseline, 43% had already declined, okay? And at discharge, you can see that 45% stayed stable, and 18%, 45% stayed stable, and 20% recovered in the hospital. So 65% were discharged with their baseline function 2 weeks prior to admission. On the other hand, during hospitalization, 12% of the people who came in stable declined in their ADLs, 18% didn't get better, and 5% declined both before the hospitalization and during hospitalization. So 35% of patients were discharged with worse than baseline function. That's a lot. And these folks did not all have strokes or an amputation or some reason to lose the ability to walk or to take a shower or to get onto the toilet or to dress themselves. So we're going to talk about a patient to kind of make this, bring this to life. And I'm sure you've all cared for somebody like Mr. H. He's an 80-year-old with hypertension, heart failure, hearing loss, and mild dementia. He comes to the ED because his daughter finds that he has fever, cough, and weakness. He lives alone. He's independent in his ADLs and his IADLs. So just to remind you, the IADLs are being able to deal with transportation, finances, medications. Often the IADLs are the first thing to go when somebody is dementing. He doesn't drink. He was a smoker, but he quit a while ago. And these are his medications: lisinopril, metoprolol, and furosemide. So this is his exam. I'm going to put it up here. And then I'm going to ask you to either shout out or put in the chat, what's abnormal here? Okay. Temp is abnormal. Fever, okay. 38.5, you're right. Crackles. Blood pressure is low for age. Blood pressure if his norm is higher. You're right on all of this. So let's just go through these for a moment. Temp of 38.5 is high, and it's high for anyone, right? But for older adults, we oftentimes look at temperature not as an absolute number, but it's 2 degrees more than their baseline, because core temperature tends to decrease when you're older. And that's the reason for those atypical presentations that Dr. Shannon talked to you about. They come in, they've got an infection, but their temp is 37, okay? Or it's 38, because at baseline they're 35.5 or they're 36. This is a low blood pressure, all right? Shouldn't have this unless you have serious heart failure, and this is what's needed to keep your heart going, basically. And the crackles. So the thing to remember about crackles in older adults is that it is not at all uncommon for there to be more atelectasis occurring in an older adult. That deep breaths are not being taken as often. They're not exercising to the extent that you would open up all those alveoli. So when you first listen, you're going to hear the crackles. Have them cough. Then see if the crackles stay, okay? Because oftentimes people will start treating with Lasix. It's already got a BP of 100/80. It's the last thing he needs. Okay, this is the chest x-ray. I think you know what this is. Even I can read it. He's got a high white count. BUN to creatinine is high. He's started on antibiotics. Don't ask me about those. I stopped learning about those a long time ago. You bolus him with normal saline, you give him a drip, you hold the Lasix, you hold the lisinopril. And then you get called in the middle of the night for agitation, at which point you do a pulse ox. His oxygen sat is 85%, his pressure is up to 170/90. Chest x-ray now shows new pulmonary edema. Now he gets the Lasix. Foley is placed because they want to check his output. He's put on a little oxygen. Then, because he's agitated, he's attempting to pull the Foley catheter and the oxygen cannula out. He's climbing over that bed. He ends up in 2-point restraints and being given an order for lorazepam, Ativan, 1 milligram every 4 hours, PRN for agitation. I see your face, Sananda. No, way too much. Okay. So what happens to this guy who came in with a pneumonia, now has congestive heart failure? Well, they finally took the restraints off on hospital day 3 and replaced him with a sitter, okay, somebody to watch him. Whether that's going to help with the agitation or not, who knows. On the 5th day, he tried to get up from his bed and he fell to the floor. Urology was consulted because the Foley catheter got dislodged, and now he's bleeding from his urethra. Day 8, he's still confused. His urine culture is growing E. coli. He started on another course of antibiotics. Day 10, he's still confused. At this point, somebody thinks it's baseline due to his history of dementia. And so he's placed on Haldol, 1 milligram twice a day. Day 12, he's discharged to subacute because he can't ambulate. And after 3 weeks at SAR, he's still unable to recover his ability to walk, and he's moved into long-term care as his residence. So I like to look at hospitalizations after I discharge a patient as what happened that was good, what happened that wasn't so good. It's kind of my audit and feedback. So what happened that was good to this guy? Anybody want to write anything in or say something? Nothing happened that was good?
I think Richard is texting, identifying the cause of infection pretty quickly.
Okay, so we actually identified and treated his pneumonia. Okay, thank you, Richard and Galit. Okay, what else? Well, this is kind of a because he got into CHF and we helped it resolve. All right, we won't talk about why. The negatives, we managed his medications. We treated his AKI by holding lisinopril, good. Negatives, giving Ativan, you guys are going fast here. The Foley, good, all right. He fell, he bled, he had a long-lasting delirium, and I heard Dr. Standen talking about delirium a little bit last hour, and people who develop long-lasting delirium are more likely to develop dementia. Don't know why, it's just epidemiologic data. He's in the hospital longer than he wants to, and he has hospital-acquired debility, discharged to SAR and long-term care placement. So if you're making a balance here, okay, balance is kind of a question if you're in the negative column or not. So what care might have contributed to his decline? You talked about the Foley, okay, and the pros, he had pulmonary edema, it allowed you to monitor the output. It helps the staff, we have to admit, okay. The cons, if you had a Foley in and you were agitated to begin with, you might get a little more agitated. He ended up in restraints, got bleeding, got a caudy. The physical and chemical restraints, he became deconditioned from lying in bed. And as I'll show you in a moment how quickly that happens. And he had a fall despite a sitter because people fall. You can't watch them all the time and keep them from falling. There are things you can do, but a sitter doesn't necessarily make the difference, especially if the sitter hasn't been trained in what to do to prevent falls, okay? And then we've got the drugs and decline in mobility, their decline in mobility and cognition because of them, all right? So that's the sad story, just to remind you. So what happens after decline? Again, another one of these slides, it's like, wait, what is this showing? So what this is showing is the x-axis is over time. So this is 1 month after discharge, this is 3 months, this is 6 months, and this is a year. And what you're seeing in the left column is people who were discharged at their baseline function. And at the right column, people who were discharged at less than their baseline function. They have a new or additional ADL disability, okay? So if you take a look at those people who were discharged with a disability a month later, only a third were back at their baseline. 53% were still declining, and 13.5% were dead. If you look a year later, of those who survived, 30% were back at their baseline. 41% were dead. Now, I am not saying that it is the disability and the hospital-acquired disability that caused that increase in death. It may be that's a marker for that, but nonetheless, these people do not do well. All right. So first take-home point, hospitalization can be a life-changing event for older adults. Before you put someone in the hospital, think about whether the benefits outweigh the risks, okay? And that's why we're trying to come up with all of these other programs, hospital at home, visiting doctors, to try and have people stay in their own homes if it's at all possible. It's not always. Okay, we're going to talk about hospital-acquired disability. And when we talk about this, there are predisposing factors and precipitating factors. So predisposing factors, and that's I'll be going over this again, that's the essence of geriatric syndromes, okay? They are multifactorial, more than one thing's causing them. One set of things are innate in the individual at that point in time. Those are predisposing, make you vulnerable. The other are precipitating, tip you over, okay? So here it's the loss of physiologic reserve and what we call in geriatrics homeostenosis instead of homeostasis, okay, for older adults because they can't get back to equilibrium. And this is a great picture kind of showing this. So what you're looking at here are physiologic reserves underneath the precipice. And physiologic reserves, when you are young, you don't have to use a whole lot to keep going. And you've got a lot left should you have stress occurring. But as you get older, you're using more and more of these physiologic reserves just to do your daily activities, to get around, to walk. And so many, many more are in use, much less is there. You get the same amount of stress, it's going to push you over, and you end up with an adverse outcome, okay? So this is part of the reason why older adults run into much more difficulty than younger adults when they get sick. So what are hospital-acquired disabilities? Well, this is the list. And I'm sure you've all seen them all in older people in the hospital, right? But if I were to show you the list for geriatric syndromes, you'd say, God, that looks very familiar, because they're really the same, okay? Again, syndromes are multifactorial. You do not want to come to premature closure. You don't want to say, this is the reason, all right? And I'll show you some examples of that as we go on. So, risk factors for geriatric syndromes. Predisposing, precipitating. This is a model that was put together for delirium by Sharon Inouye in a lovely series of papers that she did to come up with this. And basically she's saying that there are people who are at very low vulnerability for having delirium. Hopefully you're among those people. And there are people who are at very high vulnerability, like the patients we're talking about, the older adults. And there are insults that are not very noxious and usually don't cause delirium. And then there's some that are very noxious and would cause even you to become delirious. And whether that is a pill or that is a very severe illness, it certainly could happen. With our patients, these less noxious insults, like a cystitis, can create delirium. Now, I'm sure there are people who are on this Zoom call who've had a cystitis and did not become delirious, okay? But more vulnerable you are, the less of an insult it takes. So what are the predisposing factors? The patient factors are the physiologic changes we just talked about, and the pathophysiologic changes that occur because people, as they get older, get disease states. Having poor mobility or a history of falls, cognitive impairment, being dependent in your ADLs and IADLs, unintended weight loss, depression, poor social supports. And a lot of this we would now call frailty, okay? The precipitating factors are unfamiliar environment, especially for people who have mild dementia, because they're having a real problem learning new things. If you kept them at home, they'd know where everything was, wouldn't run into trouble trying to find the bathroom. In the hospital, that's not the case, lots of new things to learn. Interrupted sleep, okay? Blood draws at 4 in the morning, so you have your labs when you come in at 6 or 7. Vital signs in the middle of the night, the noise that exists. We actually did a study looking at cyanide, at medications that are prescribed in the middle of the night, and we actually found somebody who prescribed Colace, and it was being given at 2 in the morning, and I really can't come up with any reason that that would be the case. I don't even think the drug works, but I couldn't come up with any reason for that. Restricted mobility and bed rest, and we'll talk more about that in a moment, how that precipitates problems. Physical restraints, including tethers, and that includes your IV, the oxygen, the catheters, the pulse ox. Chemical restraints, which we mentioned. Polypharmacy, what do as internists? We prescribe drugs, and in the hospital, we prescribe a lot of drugs, and we don't take away a lot of drugs, okay? More drugs, the more adverse events. Malnutrition and MPO, we have people not in catabolic states, not getting any energy source. Sensory deprivation, no glasses and no hearing aids. Why do people not bring their glasses and hearing aids? Because they're expensive. And what do? We lose them. So this is a big problem. And we treat patients as dependent. We do for them. And that's a nice thing when you're a caregiver. But people have to keep doing things on their own. It's really a use it or lose it situation. So this is an old picture from 1993, but it is so true. So this is Dr. Creditor put this together. These are things that happen during usual aging, and we'll go through them in a moment. So muscle strength decreases. Older adults lose strength and mass at about 3 to 4% per year. Okay, and I hate to tell you guys, if you're in your 30s, you're getting to your peak. So it's downhill from here. And what's the loss of strength per day? 5%. So if you've ever had your hand in a cast, your arm in a cast, you know how atrophied that arm is afterwards, okay? 5% per day. And the biggest thing to remember is you lose it fast, it takes a long time to get it back. Ventilation. There's a decrease in the VQ, there's an increase in the VQ mismatch as you get older. So PO2, actually there's an age-related way of looking at what PO2 is. The reasons are that you're more restricted than you were. Bed rest further decreases PO2 by 8 millimeters of mercury. Okay, and these are the reasons. So using the formula at the top, the PO2 for an 80-year-old should be 70. They're at bed rest, it's 62. You're getting kind of tenuous. All right. Bone loss, this is amazing to me. An acutely ill person who's catabolic and at bed rest, 50 times the usual rate, and new bone formation stops. Vasomotor instability. After you, lying down is a diuretic state, basically, okay? You're gonna lose lots of fluids. The cardiac output goes down, the stroke volume goes down, blood pressure goes down, all right? So what we see a lot in the hospital is this happens, people take folks off put them on a no salt diet, it goes down even further. Okay. They take them off their blood pressure medications. A week later, they come back to the hospital, to the doctor's office, and their blood pressure is high. Altered thirst and nutrition with age. Your sense of taste decreases, not just with COVID, but with age. I don't have to tell you what hospital food tastes like, okay? And if it's not salted or seasoned, it's much worse. When they get into the hospital, a quarter to a third of people are already under or malnourished. And it's a strong negative predictor of clinical outcome, okay? These are markers that people use. Albumin is not really a marker for nutrition, but it is a marker for severe illness and total lymphocyte count. So these are some of the ways to look at this. And then if you're going to look at the thirst part, the thing to remember is old folks run dry, okay? You will rarely see a specific gravity of 1025 in a bone dry older person. And there's several reasons for that. One is that studies have actually been done making people, young and old people, hyperosmolar, and showing that young people reach for something to drink and older people don't. And this starts, you know, young old. There are 70-year-olds who have this problem. The renal concentrating ability is often impaired because that medullary gradient is washed out. And salt wasting increases. So the other thing to remember about this is when you're looking for SIADH, older people have more salt wasting. So they may actually be hypovolemic and have salt in their urine. Skin breakdown, these are the places, you know that, for pressure injuries. And if the direct pressure is more than the capillary filling pressure for more than 2 hours, you begin to necrose. The other thing is people slide down their beds. And since as you get older, you lose your subcutaneous tissue, it's much easier to have a skin tear occur from that. So here we are, back to usual aging, all those terrible things that happen. Then you put somebody at bed rest, and then what happens? They get deconditioned, they fall and fracture. Sound familiar? Dehydration, malnutrition, they can get delirious, they get physical and chemical restraints, they may aspirate, catheters get put in, pressure injuries occur, infections occur, and this is where they end up. So the take-home point. Get your patients out of bed as quickly as you can. Just sitting up gives them 8 more millimeters of oxygen, okay? Get them up as quickly as you can. Going to spend just a moment on diagnosing delirium because, as we said with this patient, they said that the confusion in this patient was due to his dementia, which he'd had the whole time. What's the key feature? What's the biggest difference between dementia and delirium? I'm going to answer because I can't ask you. Dementia is a problem with memory, okay? Delirium is a problem with attention. People cannot pay attention. So how do you test for attention? I'm going to put it in the chat. What do you use to test for attention? Does a rock float or sink? Okay. Good. Days of the week. Cam, spell world front and backwards. 7S, 7S. All right. You did exactly what I want you to do. So, poll time in the chart, in the chat. Percentage of people in the US who are not delirious, okay, or demented, who can correctly do serial 7s going from 100 to 79. 20%, 40%, 60%, or 80%. Oh, we're kind of all over the map. Any others? 20, 40, 60. 80. Anybody for 80? No, okay. All right, so here's the data. Only 43% of people in this country who are not delirious can do this. All right, the only delirious patient I ever had who could do this was a math teacher. All right. World backwards is not that much better, okay? It's 74% correct, and it's very culturally and educationally dependent. So what can you do? Well, you mentioned what you can do. You can ask the months of the year, the days of the week, forwards and backwards. I always ask them to do it forwards, A, to make sure they know what I'm talking about, and B, because it gives them a win. It kind of builds confidence, and then you go backwards. And when you go backwards, you can say to them once, okay, after you tell them what you want, you can say, and what comes before December, and see what they do. Now, I don't know if you guys watched Grace and Frankie, the TV show, but there is a great episode in the first season where Jane Fonda gets delirious and can't do this, okay? It's really very funny. The other things you can do are random digits, forwards and backwards. The biggest problem with this is that you have to remember what the random digits are. So choose something you know, all right? Phone number, your zip code. And if somebody can't speak, they can do cancellation tasks where you ask them to nod their head or tap the table every time you say the letter A. And then you say A, B, A, B, D, A, and you do that for 20 times to get a sense. The confusion assessment method, some of you mentioned, that's also was actually Dr. Inui's geriatric fellowship project. She's gone a long way on this. And what this is, it's a screening method that somebody has acute onset, and oftentimes this is historical that you're going to hear from the corroborating family members, and a fluctuating course. And it's a fluctuating course that's hour to hour, not like dementia where it's sundowning at the end of the day and really good in the morning. But this is a sort of thing where you go onto the floor and the family says, she has no idea what's going on. The nurse says, she was perfectly fine. She could tell me about her daughter and today. You walk in, the patient can't tell you if she had breakfast. All right, then you say to yourself, delirium may be going on here. Inattention, we just talked about. Got to have both of these. And then either disorganized thinking where you really cannot understand what the person is saying or trying to say, or an altered level of consciousness, and that can be being a lox, not doing anything, a hypoactive form, or it can be delirium as in DTs, where you're agitated and all over the place. So what I'd like to do for the rest of our time together is talk a little bit about how do you prevent these hazards from happening. And I want to talk in particular about 3 areas: immobility, delirium, and to prevent, and to treat agitation without restraints or antipsychotics, okay? So what I'd like you to do is in the chat, put down one of these and say something that you as a doctor could do to prevent somebody becoming immobile, somebody developing delirium, or how you would treat agitation without restraints or antipsychotics. Physical therapy, yay. PTOT, yay. Sleep hygiene, good. Melatonin, good. Frequent reorientation, a window bed, great. Music therapy, I love it. Agitation treatment with sitters, I missed what that other one was. And checking on them, reorient someone, tell them where they are. Family members visiting, yes, and you can even call the family member on the phone. Sometimes that's helpful for them to hear the familiar voice. Minimize nightly interruptions involving family to visit. Yeah. So there are a lot of things that you can do. And this is your business. This is not just the nurse's business. This is your patient. And you don't want the outcomes from this, right? Minimize blood draws. Give them a bowel regimen. Wonderful. So let me just give you a couple of quickies here. Out of bed to chair, ambulate with assistance, cane or a walker at the bedside, PT consult, educate the patients and their families about the importance of getting out of bed. This is a generation who thought of going to the hospital as a rest, okay? And they're also afraid that somebody's gonna fall. The staff is also afraid that somebody's gonna fall, but there's no evidence that keeping somebody in bed decreases falls, all right? It increases the conditioning. We'll talk about that in a moment. Get rid of the tethers if they don't need them. And if they can't get to the bathroom, give them a bedside commode, okay? For delirium, the orientation you were just talking about, there's lots to do that helps with that. Sensory aids, glasses, eye drops, pocket talkers, hearing aids. Sleep, we just talked about, and you mentioned many of these things. Nutrition and hydration. Dentures, same problems, hearing aids, okay, they're expensive. Nutrition consult, supplements, get rid of restrictive diets. There's no reason for them to be on a no salt diet if they're not on a no salt diet for a reason that makes sense at home, or they don't have a new problem that requires a no salt diet. Make sure the water pitcher is nearby and offer them some water when you come in. If you can't understand what they're saying, give them a sip of water. It's amazing. They're hydrated, you can understand what they're talking about. Wake the patient when the tray arrives, okay? Let the family bring food from home. Review medications daily because there are a lot that cause delirium. The tethers again, the mobility again, the pressure injury prevention, frequent turning, and optimized pain management because people always think about the pain medications causing delirium. Pain itself causes delirium, okay? And then agitation and hyperactive delirium without restraints or psychotics. If it's delirium, then identify the precipitants and treat them. Increase nursing surveillance, sitters, involve family and friends, modify medications if they're problematic. Reality orientation, explain it to people, reassure. So often the agitation is because they don't get what's going on around them. When I was a new attending on a nursing home for patients suffering from dementia, a neurology resident went into a patient's room to get an LP, and the patient socked him, okay? And he came out mad as. There was another person in the room who said to me when I went in, the patient was lying on his side. The resident went in, didn't say hello, didn't do anything, lifted up the pajama top, put the betadine on, put the lidocaine in, and the guy turned around and socked him. So would I, okay? I mean, that's an appropriate response. So help them understand what to expect, what's going on. Improve hearing and vision, modify the environment to increase safety. And then reconsider whether they really need NG tubes, IVs, and catheters. In general, we have found that anybody who's in the ICU who can self-extubate probably doesn't need that tube, okay? So did these interventions for these three different things seem similar to you? Well, they were, because geriatric syndromes can cause other geriatric syndromes, and they go back and forth. If you don't sleep, you're more likely to fall, okay? If you don't sleep, your cognition is going to be worse. A word about restraints leads to everything bad. Do not decrease the risk of falls. This was actually looked at, and it may increase them. And you're more than aware of what the Joint Commission said about the least restrictive environment of care, right? Okay. Antipsychotics kill people. Both atypical and typical antipsychotics do it. It occurs early in the course of treatment. The only data we have are from RCTs that were like 10 weeks. So it's early in a 10-week period. Will a single dose do it? I don't know. All right. Certainly can have an effect on a QT, but I don't know. For atypical antipsychotics over that 10-week period, The number needed to harm, and harm here is dying, okay, so it's a big harm, is 100. Treat 100 people with one atypical antipsychotic for 10 weeks and one is dead. All right. No differences in risk by the drug, the severity of the dementia, or the diagnosis. For typical antipsychotics, the risk was greatest early on with higher doses. If you need to use them, and there are times you need to use them when the person is a risk to themselves, to somebody else, they do work, okay? Take a look at the starting doses here. For Haldol, and this is oral. Haldol, it's half dose if it's IM or IV. Risperidone, 0.25. Olanzapine, 2.5, okay? Our ED seems to love 5 milligrams IV or IM Haldol. And they put on at least a day, sometimes 2 or 3, to length of stay. So that's what you can do. What can the systems do? Well, there are a few things that have been shown to be very helpful. And these are hazards that are linked to processes of care. So for delirium, there's something called the Hospital Elder Life Program. Again, it's Inui. I'm telling you, she made her whole career on this. And it's an intervention designed to counteract many of the things that we do wrong in the hospital. What they did, this was at Yale. Initially, they screened patients who were 70 and older for at least one risk factor for cognitive or functional decline. And then they targeted 6 that were associated with delirium. We are not talking rocket science here, okay? We're talking doing orientation and activities with someone who is to prevent cognitive impairment or worsening cognitive impairment. They actually gave a back rub, okay, to people who are having trouble sleeping, gave them chamomile tea, gave them some music, told them, we will come back in an hour, and if you're still not asleep, we'll give you the drug, okay? Early mobilization, minimized immobilizing equipment, the tethers. They had visual aids, they had glasses, they had magnifying glasses, adaptive equipment, large print. Hearing impairment, there are pocket talkers you can use, and actually older people are more likely to have impactions from earwax because the earwax is drier. If you get rid of that, they can hear better, okay? And early recognition and repletion of volume problems. You've all seen the patient, comes in totally confused, you water them, and the next morning you come in and they've blossomed, they're a full person again, okay? Water is a wonderful thing. What happened when they did all this? They reduced the incidence of delirium from 15% to 10%. They reduced rates of functional decline during hospitalization from 33% to 14%, and they reduced length of stay. And this has been replicated all over the place, okay? And they reduced the cost of the hospitalization. There are also a group of medications which you should know about as individual things you can do to try and decrease these hazards. These are, we call them FRIDs and DRIDs, okay? Fall risk increasing drugs and delirium risk increasing drugs. And they're pretty much the same with the exception of some of the antidepressants that don't increase delirium. But all of these increase falls as well. So what could we do as a system? What we've done is we took the default doses in EPIC, and we did this at Mount Sinai, and I believe it was done at Morningside, but we really need to make sure it was. We looked with one of my fellows at all of those medications and what the default doses were in EPIC, and we found extraordinary doses. So for Seroquel, it was 100 milligrams was the default dose. We start with 12.5 with our patients, okay? And people tend to give the default dose because it's there and they're not thinking and they just go. So we have been able to change the default doses of all of these medications in EPIC for 65 people who are 65 and above, okay? So trying to hardwire it a bit. Functional decline. So the acute care for elders unit, which I understand is getting up and running where you are. This is an interdisciplinary geriatric focused unit designed to maintain independence. Patients are screened at admission if it's at all possible. You know, it's harder and harder these days because we don't have extra beds. But what did they do? So they fixed the environment. They put carpeting in, orientation tools. They changed the lighting, sensory aids, like we were talking about the pocket talkers. This is in the days that people were around long enough to have dinner together, be well enough to have dinner together, not so much anymore. The nurses and the aides were trained in geriatrics. Function and cognition were assessed daily. And remember, assess cognition daily. You check the heart, you check the lungs, you check the legs, the belly. What's more likely to change day to day in an older person in the hospital? Okay, the legs or the cognition? And interdisciplinary care so that all parts of the patient are being considered. And then discharge planning from the beginning. What were the outcomes? Reduced use of restraints and high-risk drugs, reduced incidence of functional decline, increased likelihood of discharge to home, reduced hospital length of stay and cost, increased satisfaction, not just amongst, there's a T missing there, the patients, but the nurses and the physicians as well. So I'm going to finish with kind of 10 commandments of care for taking care of these patients. And the first I've told you about before, okay? Get that patient moving. Don't let them be in bed. The fewer drugs, the better. Review the medications frequently to do that. Get the IVs and the catheters and all of those out as fast as you can. Don't restrain people. Think about it. If you were restrained, what would your response be? Usually in a hospital setting, you'd get agitated, right? Yeah, just makes things worse. Here we go, assess and monitor mental and cognitive status daily. This, I'm just quoting Dr. Sannon. Watch for depression. Being in the hospital is a sad thing. You don't necessarily need an antidepressant. Sometimes if you got medical students, they're great antidepressants, okay? Let them talk to the patients. Pay attention to the amount of food consumed, okay? Consider supplements. Studies that have shown that ensure and those sorts of things given to people who are malnourished in the hospital results in better outcomes. Start discharge planning as soon as they get there. Try and figure out what's going to happen with this person and make sure the patient and the family are involved in the decision-making and the advanced directives. If you're a visual learner, this is something Dr. Fernandez did when she was a fellow with one of our medical students who's now an attending at Wake Forest. But basically taking somebody, you know, they're not quite this bright and bushy-tailed when they get into the hospital. But then we isolate them, especially during COVID. We don't feed them. We don't let them sleep. We don't let them move around. We give them a lot of drugs. They pee on themselves. It's not fun. We put restraints in. They're in an unfamiliar environment. They don't have their glasses, their dentures, or their hearing aids. And this is what you get, which you now recognize as geriatric syndromes and hospital-acquired disabilities. Okay, so do whatever you can to avoid this. Thanks, and I think we have time for a few questions.
Thank you so much, Dr. Leipzig. And if I may humbly add, I do also think involving the outpatient care team early on during their admission is also crucial. At least it's proving to be vital. During our inpatient geriatric team, I think they do have, broad knowledge of the patient, and they can help even coordinate the transition of care once they're ready to get discharged.
Yeah.
Guys, I'm gonna mute myself. I'm gonna let you ask any questions or post them in the chat. And if not, I also had a question, maybe out of curiosity. You mentioned before how I guess you were discussing how our EMR will default doses that are not appropriate for the older patient population. And I think that's a great initiative. And I'm wondering, while we haven't seen that in our Epic at Mount Sinai Morningside, and anyone who's been recently in the Geri team may correct me, what other strategies can we put in place while we're taking care of older adults to consider nuances?
Okay. So the hospital itself, your hospital is doing things. I'm sure you've been talked to about the age-friendly initiative, okay, to try. And So we in geriatrics talk about the 5 M's of geriatrics. 4 of them are the age-friendly initiative. And those are things that systems can do. And that include, and as well as you, which include making sure you know what matters to the patient, what makes a difference to them, what they want out of the care that you're giving them, that they're able to walk around and not fall, excuse me, that they're only taking the medications they need. Think of it as Goldilocks, okay? Not too much, not too little, just right for the medications that they're taking, and that their minds are as clear as possible, and that their mood is as good as possible. The other one is something called multi-complexity. And that's really what you're dealing with people who are 80, 90 years old and have 80, 90 years of medical things having happened to them, okay? And so you really have to individualize things for each patient. And so I think that's the one thing that as individual practitioners, we really need to think about. Am I going to suggest this colonoscopy to this person? Okay. Will they live long enough to die from a colon cancer, or are they more likely to die of something else sooner? Okay. And there's a lot more that's in the literature now to help us think that through. But I try and think about what my patient's life expectancy is likely to be, and what we're doing that really helps them and what might not be so helpful. Okay, just to give you a sense, I usually ask this as a question, but so median life expectancy is the age to which 50% of people who are a certain age will live to be. Okay, so 50% will be that age or more, 50% will be that age or less. You have a life expectancy when you're born. The longer you live, the longer your life expectancy is going to be. For 65-year-olds in our country, life expectancy at the moment is 84 and a half. When I have asked interns this in the past, I've been told 70. I tell them, you got to get out more, okay? All you're seeing are the sickest, oldest people. That's not who's out here in reality, all right? So it's really important to recognize that the greatest variability among individuals is among older adults. You guys are much more similar to each other physiologically, pathophysiologically, than older adults are. So get a sense of that, get a sense of what they want, and work with them, okay?
Hi, Dr. Leipzig. This is Dr. Prigolene. I'm one of the program directors.
Hi.
Thank you for this presentation. It was wonderful. Something that I don't know if it's been studied. It's just my perception from working in the hospital for a long time. Is in the thing, the series of things that come together to facilitate delirium, really, in the elderly. One impression that I have is the use of the hospital gown as something that really helps with depersonalization. And with each of my patients, I insist that the family members to bring them their own, pajamas or whatever, to help them remember who they are and that they don't have to assume the role of the sick person, to get them out of bed and put them back on their feet. I'm not sure if that's been studied or not, but I was curious about that.
Yeah, I don't know that it's been studied, but I think it's a phenomenal idea for so many reasons. I mean, the hospital gown is for us, not for them, okay? It makes it much more easy for us to access whatever it is we need to access, all right? But I had the experience when I was in training of not recognizing my patients when they were dressed and walking, because I didn't really see them, okay, when they were in bed and they were sick, etc. So I think that's a marvelous idea, and also to help them to think about what they can do for themselves.
Mm-hmm.
Yeah, great idea.
Thank you.
Sure. Jonathan, is that a hand I see? Jonathan Oxman, there's a hand up. I don't know. Oh, nope, it's not your hand. It's my hand that's up. Sorry. It's my cursor. All right.
I just want to say thank you. It's great to see you.
Oh, hi, John.
It's great talking about this. I think that, it's really important for them to remember what's outside of the hospital because they get so focused on what's inside.
Absolutely. Yeah. Remember, you gotta balance.
Especially as I get closer to being one of those old people, I want everyone to remember that.
Well, that's the one thing to really remember is that if you're lucky, these people are going to be you. So do everything you can at this point in your life and as you get older to do things that will make a good old age for you, And there's a lot that's under your control, including trying to be as flexible and adaptable as you possibly can, because who knows what's waiting, Okay, well, thank you. It's been a pleasure seeing you and hopefully sometime in person.